Bismillahir Rahmanir Rahim. This is Professor Abdussalam Yassin Taha from the College of Medicine, University of Sulaimani, giving a talk on forequarter amputation for primary malignancies. You can watch this lecture and other lectures by visiting my YouTube channel using the URL at the bottom of the slide. Forequarter amputation, also known as shoulder girdle or interscapulothoracic amputation, refers to surgical removal of the bones and soft tissues of the upper extremities, including the scapula and clavicle. Ralph Cumming performed this operation for the first time in 1808, while Dixie Crosby was the first to use this procedure for a case of osteosarcoma in 1836. In this lecture, the stories of 2 men and 1 boy from Iraq with advanced primary malignant tumors of the proximal upper limbs, namely fibrosarcoma, ulcerating basal-cell carcinoma, and osteosarcoma, cured by forequarter amputation, are presented herein. The pros and cons of this procedure are discussed in view of the literature. The first case was a fibrosarcoma of the right shoulder girdle. A man of 55 was admitted to Basra Teaching Hospital on September 16, 2001, because of a big right supraclavicular mass of 3 years duration associated with severe shoulder pain radiating down the arm. The mass was diagnosed as a non-epithelial tumor by fine needle aspiration and cytology done 3 months earlier. Physical examination revealed a solid mass bulging above the right clavicle and fixed to the deeper structures, with marked varicose superficial veins on the anterior chest and right upper arm, associated with a palpable right radial pulse and a normal chest examination. So that is the photograph of our patient showing a big supraclavicular mass fixed to the deeper structures associated with varicose superficial veins on the anterior chest and the right upper limb. And the patient had this mass for about 3 years, along with pain in the shoulder region radiating down the arm. Plain chest radiograph, as well as a complete blood picture, were normal, with an erythrocyte sedimentation rate of 40 millimeters per hour. MRI scan showed a huge, well-defined, encapsulated mass extending up to the neck and down to the axilla without an intrathoracic extension. So that is the MRI, another review with contrast injection, showing a big supraclavicular mass extending into the neck as well as down to the axilla, but without an intrathoracic extension. MRA, or magnetic resonance arteriography, revealed a highly vascular mass fed by a short stump of the right subclavian artery. The patient underwent 2 operations. So that was the picture of the patient after starting the general anesthesia through a single lumen endotracheal tube. And we can see the big mass as well as the varicose superficial veins on the anterior chest and the right upper limb. The first operation was unfortunately not well planned. A direct incision over the mass was followed by severe bleeding from a highly friable vascular tissue. The wound was therefore closed over packs, and the biopsy result was an undifferentiated sarcoma. The second surgical intervention was carried out 1 week later after a discussion with an orthopedic surgeon and informing the patient about the consideration of a radical resection via Forequarter amputation. In the second operation, proximal control of the innominate vessels was achieved by a median sternotomy with supraclavicular extension and clavicular resection. The major veins were greatly engorged by mass compression, while the subclavian artery was coursing through the tumor. After tedious dissection, subclavian vessels were isolated and ligated proximal to the mass. Forequarter amputation was then completed in a lateral position. The mass was 23 by 9 by 8 centimeters in size, involving the head of the humerus. Good hemostasis was followed by placing a mediastinal, right pleural, and submuscular drains, and primary wound closure. The post-operative course was uneventful. The biopsy result was a fibrosarcoma. The patient received post-operative radiotherapy and was well for about 5 months after surgery. The second case was a basal-cell carcinoma of the axilla. A man of 50, a known case of malignant ulcer of the left axilla for 5 years, presented with recurrent bleeding and loss of sensation over the forearm. He was referred to Suleymaniya Teaching Hospital in August 2004. Left forequarter amputation was performed in collaboration with an orthopedic surgeon. The biopsy result revealed features of basal-cell carcinoma, solid and adenoid types, with invasion of the wall of the axillary artery, as well as perineural invasion. The patient had a smooth post-operative course. So that is the picture of the patient after the operation, and the patient is smiling, reflecting satisfaction with the result of the operation. The third case was an osteosarcoma of the left shoulder. A boy of 9 presented with a huge, painful swelling of the left shoulder of 2 years duration, diagnosed by a previous open biopsy as an osteosarcoma. On examination, the old scar, as well as the dilated superficial veins, were visible, and the mass was hot and tender to feel. Plain chest X-ray and an X-ray of the shoulder region showed a big soft tissue swelling around the left shoulder with involvement of the left humerus. The patient was treated by left forequarter amputation with a smooth post-operative course. Discussion. The shoulder girdle is the third most common site for malignant bone and soft tissue tumors. In a review of more than 46,000 cases by the National Cancer Center, tumors around the shoulder girdle involving the scapula, distal clavicle, and proximal humerus constituted 12% of all primary malignant bone tumors treated in Japan since 1972. When faced with a malignant tumor of the proximal upper limb, the goal of surgery should be the complete removal of the tumor and preserving the limb. Unfortunately, this goal is not always achievable. Limb salvage procedures may not be feasible in advanced tumors involving vessels and/or nerves. In such circumstances, removal of the tumor necessitates limb sacrifice, that is, a major amputation. Fortunately, this option has become less frequently required with the advent of new surgical techniques that permit limb salvage. Daigler et al. Confirmed this fact by studying 1,597 cases of limb sarcoma in which proximal major limb amputation was necessary in 37, 2.3% of cases only. Initially, forequarter amputation was used to treat traumatic injuries of the upper limb. Later on, it became the standard of care for treating and curing patients with bone and soft tissue sarcomas of the limbs. However, this operation is a major undertaking, resulting in the loss of a limb, which is an important part of the body schema. Most patients and surgeons dislike this operation due to its significant disfigurement and the frequent occurrence of phantom limb pain reported in 87% of patients. Phantom limb pain, beside other factors, account for depression and even suicide attempts in some patients. So is there a way out? It is logical that surgeons began to search for new surgical techniques that permit removal of the tumor and at the same time preserve the upper limb. This led to the concept of limb salvage surgery. Limb salvage for tumors of the shoulder girdle was first described by Limberg in 1927. Expert authors suggest that limb salvage surgery should be considered only when adequate surgical margins can be obtained, and on the other hand, recommend forequarter amputation for patients with complicated neurovascular involvement. So what to do when limb salvage is not possible? The answer is straightforward. Forequarter amputation would remove the entire limb, including the tumor, providing mostly a palliative solution for those with metastatic disease, while it gives a chance of cure in the absence of metastasis. Indications. As we said, in the past, forequarter amputation used to be done for severe traumatic injuries of the upper limbs. At present, curative and palliative resection of malignant tumors of the arm, axilla, shoulder, and scapula represent the most frequent indication for this operation. As limb-sparing surgery has evolved, forequarter amputation became less popular, though this procedure still has a definite role in the management of selected patients with malignant tumors of upper extremities, particularly the advanced cases or recurrent tumors after conservative treatment. So to summarize, the current indications for this procedure: number one, advanced tumors adjacent to crucial structures and close to the trunk. Number two, cases with a fungating tumor growth, ulceration, impending vascular disruption, intractable pain, paralysis, sensory disorders, lymphatic edema, and a largely useless extremity. Number three, brachial plexus and subclavian vessels involvement. And number four, forequarter amputation has a role in the treatment of recurrent breast cancer, of which 23 such cases have been described in the literature so far. Technical tips. The technical aspects of this major surgical intervention deserve special attention, particularly the team approach, vascular control, and wound closure. The patients presented herein were managed by a team of an oncologist, vascular, and orthopedic surgeons. Proximal control of subclavian vessels is a safe precaution to minimize the blood loss. A plastic reconstructive surgeon may be required if a skin graft or biocutaneous flaps are needed to achieve wound closure after shoulder amputation. What about the quality of life after this procedure? In regard to the quality of life following the procedure, there are different opinions. Wittig et al. Reported pain relief and improvement of quality of life after proximal major amputations. Likewise, Daigler et al. Reported that most of their patients have accepted the aesthetic outcome of the operation and felt a significant improvement in their quality of life. The greatest benefit was observed among those patients with low preoperative life quality and high pain levels. In contrast, Taira et al. Believe that the functional result after forequarter amputation was extremely poor, even if better oncological results were achieved. Around 15.6% of patients considered their quality of life worse than before the operation. 32% of the amputees had suicidal ideas, and 65% suffer from sadness, probably related to phantom limb pain beside other factors. Survival following forequarter amputation. A prospective randomized trial from the National Cancer Institute concluded that the rate of disease-free survival and overall survival of limb salvage versus amputation were comparable. Most patients treated with palliative forequarter amputation survive less than 2 years after surgery. However, when this operation is performed for patients with solitary lesions without associated co-morbidities, then it can provide the patient a symptomatic relief and even a chance of cure. So what are the take-home messages of our lecture? Despite the significant disfigurement imposed by forequarter amputation and the frequent occurrence of a phantom limb pain, forequarter amputation does have a vital role in the management of selected advanced proximal upper limb malignant tumors for which limb salvage is not feasible. Hence, surgeons need to be familiar with this uncommon yet important operation. Well, this presentation is based on an article. I have published this article in 2016 in the Journal of Neurological and Orthopedic Medicine and Surgery, which is the official journal of the American Academy of Neurological and Orthopedic Surgeons. And this is the list of references of the article. And with this picture of the Central Bank of Iraq by Zaha Hadid, I would conclude my lecture. Zaha Hadid is a famous Iraqi architect and is a major, recognized as a major feature in the architecture of the late 20th and the early 21st centuries. So thank you for watching this lecture. This is Professor Abdussalam Yassin Taha signing off from the College of Medicine, University of Sulaimani.